Anyway, last but certainly not least, Dr. Balducci will discuss complexity. He needs no introduction.
First of all, I apologize for my southern accent. Those of you who are not used to it, please bear with me. I will try to speak very slowly. I was hoping by now that everybody would have left, so I did not have to give my talk, but I saw that I have a few faithful, and so I will stay here and talk. I will start in a little different way. I'm going to discuss a myth of old Greece to introduce the concept of complexity. I don't know many, and here is my first statement, is that the survival of older cancer patients is complex. It is not enough to kill the Minotaurus. It is necessary to exit the labyrinth. I don't know, many of you remember the myth of the Minotaurus. The Minotaurus was a combination was a man with the head of a bull, because he was born from the love of a woman with a bull. And his stepfather, the king Minos, had him closed in this labyrinth so that people could not reach him. And even if they could reach him, they could not get out of the labyrinth. Unfortunately, the Minotaurus had a real bad habit. He used to feed himself from Greek virgins. Nowadays, he would have died of starvation from extinction of his favorite food. But at that time, he was depleting the brooding reserve of Greece. So it was urgent to destroy him. And so this hero Theseus went in and eventually could kill the Minotaurus, but once he had killed the Minotaurus, he had problems in getting out of the labyrinth. How he did that was through the help of a caregiver, Arianna, who gave to him, allow him to, with a thread, to find his way back. The point I'm trying to make, however, is that when we talk about cancer in the older person, it's not enough to kill the Minotaurus. It's not enough to kill the cancer. It is necessary also to exit the labyrinth. It's necessary to keep the patient alive. That is what we call a complex situation. We are now going from ancient Greek to Latin, and there are two words that often we use intermittently, but they are quite different. One word is complicated, that derive from complicare, which means to fold together. A fabric which is folded is easily unfolded. Complex derive from complexere, which means to weave together. And if you have a carpet with a folded design, maybe the only way to correct the design is to unweave the carpet. So a complex situation is really complex. Is a situation where you have an intermingle of problems, and when you try to afford one problem, you may be faced with more different problems. Is that clear? And that is what cancer, and we don't have any randomized clinical trials which will tell us how to deal with a complicated situation. We don't have a way with a complex situation. We don't have a way to measure complex. We don't have any index like the performance status to indicate what complex is about. That is one of the reasons why in geriatrics evidence-based medicine is referred to as evidence-biased medicine, because what may happen in a very well determined population, selected population of people, may not have any relevance with the general population. And I'm not sure I have the solution, but I try to make some proposals on how to afford complexity. This is the case of a woman that is very well known to all the people working with me. She's 86 years old, and she had hemiparalysis on the left, secondary to thrombosis of the right middle cerebral artery. The paralysis had developed 5 years earlier, when her platelet counts were more than 1 million. She was diagnosed at that time with primary thrombocythemia and was treated with hydria. 3 years later, 3 years earlier, 2 years after the paralysis, she had colon cancer, stage 3-1, she had colonic resection and no adjuvant chemotherapy. Eventually, a hired caregiver who was watching her found a mass in the breast, a small mass, and was referred the patient to me with and the patient was referred to me with a moderately differentiated adenocarcinoma, positive for hormone receptors, negative for AGR2. The patient and the family refused surgical treatment, and that probably was smart. So anyway, that was not an option. This is important because I think we need to emphasize that in dealing with the older person, the first way to deal with complexity is to decide what are the patient desires and the patient values. A value history is one of the most important aspects of a geriatric history. So, but on the other side, it would have been very reasonable also not to touch her and say, just watch it. Yes, this small, she already had 2 problems, the colon cancer and the stroke. Clearly, she was not going to die anytime soon of the breast cancer, but the patient did not like that little node there and would like to be treated. So we started her on exemestane. 1 year later, and she went into what looked like a good partial remission. 1 year later, her platelet counts increased to 500,000 and the white count to 21,000 with some immature forms. Surely enough, she was found to have chronic myelogenous leukemia. I would have, I don't know if she had chronic myelogenous, I don't know if at the original they have checked her BCR able. Should have been done if it was not done, that's what it is. But now she had. So we started her on imatinib, 400 milligrams a day, and we reduced the dose at 300 milligrams a day because she developed neutropenia and fluid retention. 6 months later, diffuse abdominal pain. She had pelvis, CT scan of the abdomen and pelvis reveals kidney stones, but the urologist refused to perform lithotripsy because the patient was on warfarin. And the cardiologist refused to discontinue warfarin because of concern of a new stroke. In other words, the urologist said, as long as the patient doesn't die as a lithotripsy is not of my business. The cardiologist said, as long as the patient died of kidney failure instead of a stroke is none of my business. That was the answer. Also, she had an increase in her CA went up to 20, and the PET scan revealed a strongly positive stomach. I proposed a colonoscopy, but the patient was not very fond of it, and the rest of the family supported the patient. So we did something which Dr. Emanuel would have strongly disagreed with me. We did a PET scan to see if she had a positive PET in the colon. That was a non-traumatic procedure. And I hope nobody's here from Medicare and CMS, otherwise they may decide to not to pay for that PET scan. But anyway, the PET scan only showed the presence of stomach positivity, and she had gastric polyps. General situation, she was homebound with a husband who was demented, meaning mental status of 23. Now the husband is deceased. But the husband was driving her to the hospital, and she had a hired caregiver. She had a married daughter whose husband is frequently absent for business, and so the daughter is responsible for the medical decision. She also works full-time and takes care of 2 children, and one of the children had chronic asthma. The daughter was frustrated, and she asked whether there was not cheaper medication than imatinib for the management of chronic myelogenous leukemia. That is what I call a complex situation. But if you think that is what we see in the clinic every day, practically, so this is the geriatric oncology, and that's why how many clinical trials we can do, how many patients like this we can find to have a randomized clinical trials with a p-value of 0.005 and the power of at least 80%. I don't think so. What do we do? What we should do with the patient? Pretend that they don't exist? Because we cannot measure them. That's what Dr. Emanuel would do, is that right? But no, I mean, I mean, I know Zik, come on, it's not, let's say that he's as quiet as I am, okay, in terms of, I kind of enjoy his tirades, but let's say he's as quiet as his brother who almost lost his mayorship of Chicago. Anyway, thanks to his lovely personality. Okay, so how are we going? I don't know if there is. These are the questions. Management of breast cancer. What should we do? Surgery? No, she say no. Stereotactic radiosurgery. That has not been. That might have been an option, but our breast people don't like to do that, and I don't blame that. Hormonal therapy, that's what we decided to do. Observation would have been reasonable if that was acceptable to the patient. Should we have staged the patient? How many people would have staged this patient? You would? Why?
Because to rule out the risk of fracture.
What? What? Explain yourself. I really... That sounds new. Why would he? I mean, she already could not move. She was paralyzed on the left. How are you? Come on, Martin. What have you smoked today? Okay. Anybody else besides Dr. Exerman would have staged this patient? Well, if the surgery was you want to take the position, do you want to support Dr. Exterman from just for patriotism? Yeah, no. Okay, well, I mean, I think it would have been reasonable to stage her if she would have considered surgery. But since she did not consider surgery, I did not see any reason to stage her. Now, treatment of CML, would you have increased the dose of Hydrea or monitor BCR-ABL level or used another TKI in TKI? Martin, you have any other word of wisdom on what you would have done in this case?
I don't remember what happened to nobody else.
I'm sorry?
I don't remember what...
She had a good response on the breast cancer.
So she's still on response?
I'm sorry?
She's still in response?
Yeah.
But the CML got worse, right?
I'm sorry?
The CML got worse?
The CML got worse. No, she was diagnosed with primary thrombocytosis, primary thrombocythemia. I saw her, she was on Hydrea. After 1 year, the platelet increased. She started having immature form, checked BCR-ABL, she has CML. And right now, we have 5 TKI for CML. Probably 2 is all we needed, but that is wonders of capitalism in medicine. And the other wonder is that imatinib was fairly inexpensive. I mean, inexpensive was $2,500 a month, but consider inexpensive, everything is relative. But now, since to make sure that we don't use it instead of the new most expensive drug, Novartis has increased the price to $10,000 a month. So we would have increased the dose of Hydrea instead of putting her on, or would we have used interferon instead? Okay, no interferon. What would they use? Nobody, Dr. Rai is not here anymore. Nobody else remember using busulfan in the management of CML. Dr. Kish, when you remember anything about management of BCML with busulfan in our days? Well, I really think honestly, I believe that in this case, the use of a TKI was indicated. And the reason why I think it was indicated is because if the patient had CML since 5 years earlier, she was exactly in the phase in which she would start deteriorating, becoming so. And hydria, she was not responding very well to 500 milligrams of hydria. To increase the doses probably would have just been a band-aid. Interferon would have not been a good choice. Busulfan, I don't think you can even find it anymore. So you can, okay. Well, so practically, I honestly think that was a good choice. Obviously, I think eventually I called the cardiologist, I called the urologist, I had them agreeing on stopping the warfarin for a couple of days and for a few days and bridge with heparin and get the lithotripsy. Anybody would have done the colonoscopy in these patients? Would you have agreed with using the PET scan if Dr. Emanuel did not want me to? You disagree? Would you have? No.
I mean, I was a little bit curious about PET scan as part of you said PET scan?
She had colon cancer 3 years before, and the CEA went up to 20.
Okay, so the PET scans effectively staged her for both colon and breast, so
yeah.
That question is out the window. But I don't really have a good sense of how viable this woman is. If she's truly...
She's alive. She's pretty alive. I've been treating her for 3 or 4 years now. She's almost 90 and she's alive.
But she's mobile or not?
She's not mobile, but Dr. Emanuel, you don't like it? You think that she does not have a meaningful life? No, because... I'm sorry? Yeah, a little bit mobile. I mean, she's mobile on one leg. Okay. You think that is not a meaningful life?
I'm not sure.
No, look, it's meaningful to her, okay?
Yeah.
When we offer to her to come to the clinic once a month, she said no, she wanted to come more often because she enjoys seeing us. So, I mean...
But the colonoscopy would have been for a local recurrence
of the colon cancer.
Right, and that's what you thought she had. I mean, how likely was it that she was going to have a local recurrence versus?
Well, I mean, she had a colon cancer, a stage 3-1 colon cancer before. I think it's reasonable to look for a local recurrence. And of course, there were economic issues, and of course, issues with the caregiver. To tell you how important the caregiver is, I will make a confession right now, but Dr. Langer already made it. When I was a young oncologist at the VA in Jackson, Mississippi, I'm talking about 1978, when I finished my training, here came a 75-year-old man with metastatic small cell lung cancer. At that time, we used to think that was the only type of lung cancer we could treat. And he had COPD, but he was walking. He was not curable, but was treatable. And his 2 daughters told me, we don't want to take him to the clinic. We just don't have the time. We are 2 single mothers with the work to pursue. We already have enough problems. We don't have time to take care of our old father, who has no other support. So I told that patient, and now I'm not asking your absolution, but I told that patient that for him there was no treatment. And a lot of you may have some ethical problem with that. I still don't have any ethical problem because I think in 1978 home health care was not nearly as well developed as now, certainly not at the VA. And I thought that without the support of his daughters, he would have not been able to tolerate what we used at that time, by the way, which was not platinum etoposide, but was CAV, which was a terrible treatment. So, but that to tell you how important is for me the DNR status. She agrees on the DNR, okay? Okay, let's see. I'm sorry, it took a little bit of time now. What are the responses? Some people would say, like Promises, the last time I mentioned him, like Dr. Emanuel would say, this patient has 3 diseases, all of which are incurable. There is no option to improve her function. She's a terrible burden for the married daughter, since we cannot shoot her, just offer only palliative care, or if you want to be compassionate, offer euthanasia and physician-assisted suicide. And now, I mean, that's the way that Dr. Emanuel feels, seriously. I obviously disagree with this approach, and disagree not because, I disagree with euthanasia and physician-assisted suicide. I do not disagree at all with palliative care, but I disagree because the patient wanted to live. The patient had lived now 10 years with a stroke, and so euthanasia and physician-assisted suicide, I don't want to start the thing, but everything else. What about offer only palliative care? Anybody would go with that?
I would if that's what she wants.
Yeah.
I think if she wants treatment, we should at least offer some sort of treatment within the realm of reason.
And the treatment of CML really could have prolonged her survival. Treatment of breast cancer, I don't know, but okay. No, what happened here? I have a lot of problem with the. Okay. Second possible response. Technical answers. One is to use a electronic medical record. These are really the solution to everything because they allow you, is legitimate to falsify the record practically. You will not be able to put into the record what is going on, so you will ignore the problem. You make the problem disappear with a click. Or not with, if we could make it disappear with just one click would be too easy. With multiple clicks of that infernal machine. And I'm not fond of electronic medical record. Okay, that's for me the same level as the Joint Commission of Hospital Accreditation. One thing we could use some prognostic and predictive models and decisional models. And this is a Markov model, so it's complex to resolve complexity. And what it is a legitimate decision analysis model which practically consider three and improvement, death, worse, or stable, four possible outcome. And that is very fun to work with, but I don't know how well it would reflect this lady's situation. So, mammary cancer observation was legitimate for the patient, but was not acceptable. Surgery was not acceptable to the patient. So anybody would have used aromatase inhibitor and everolimus? No. Why not, Martin?
She has a huge cardiovascular history.
Yeah, but besides that, also this medication is really terrible. I don't know how many of you. I mean, I dislike everolimus more than I dislike bevacizumab. Yeah, I don't know how many. This is one of the most expensive form of torture that human mind has ever, has ever. Now, come on, you disagree with me? I still have to see anybody who does well. Jill, you had somebody who did well with that. Okay, so do you want to spend a word in favor of everolimus? No, okay. What about the new kid on the block, palbociclib? Anybody would use it? I mean, I would have proposed it just to irritate the pharmacist, but beside that, anybody would use palbociclib?
I think it's about $12,000 to just have a
Yeah, no, I know it. And with it, however, palbociclib seems to improve by double the progression-free survival. Martin, would you have proposed?
No experience with palbociclib.
No, okay, but it's available now. The data shows that would improve, would double the disease-free survival. Anyway, we started there on an aromatase inhibitor and fulvestrant because at that time was the option, and she does not have to pay for fulvestrant because it's an intramuscular medication, and there is a very good evidence that the combination is more effective than aromatase inhibitor single agent. For what concerns the CML, we have already discussed all these options. The treatment option were imatinib and busulfan. Christina, would you have considered to use busulfan or not? Why not?
Toxicity with it.
No, come on. Come on now, no, come on. What kind of toxicity? It's not more toxic. I mean, can cause infertility, but I don't think that would be a major problem in this lady.
It would be a very cheap option if you had to go cheap.
Okay. Anybody else? Martin, you don't know what is busulfan, so Corey, you remember? Never.
Precedes me too.
I'm sorry, Doctor. Probably Dr. Kish used it, but she forgot it. Okay.
It's like 2 to 6 milligrams. It was the 1960s.
We have already discussed what to use the PET scan for. Kidney stone, we have just already discussed the issue, so we went to there. And finally, briefly, I don't know how many of you have seen this picture on, this is a representation of Aeneas who is escaping from Troy. This is in Rome, in the Vatican, as you can see, Aeneas is carrying his old father on his shoulder and is carrying his son by hands. My friend Ligia Dominguez, who is a Cuban, but she lives is Colombian, but she lives in Palermo, Italy, described the current situation of the caregiver as the Aeneas syndrome. Aeneas, which is carrying his old father and supporting his young son. So that is, I think, is one of the situations that was present. What can we do on this lady? Well, first of all, as I say, I don't have the solution for a complex situation, but that is a real medicine, okay? Not 3.5 weeks in survival improvement that led to the approval of the FDA of a drug that cost $12,000 a month. One is what are the patient's values and desire? Obviously, she wanted to live, and she did not want to have the little mass in her breast. I think it's very important to have negotiation with the caregiver. You know, we talk a lot about supporting the caregiver. There are zillions of studies to support the caregiver, but those require two types of investment. Investment of time that this young woman did not have, and investment in money, because generally you have to go to So what can we do for a caregiver who is already stripped for time and money? Initiation of a less toxic treatment is observed. And of course, you know, the base is, the experience is very important in this case. And the other thing which is very, very important is the team approach. Also, I've been described in a book about my program as a patriarch. I think I try to have a team approach to our patients, and I think everybody's opinions what I was trying to do with a little bit of humor right now is try to have exactly this team approach in a situation where there is no right or wrong. I think there are some things that are wrong. Would have been wrong to operate on her against her consent, okay? Would have been wrong to do a colonoscopy, most likely. For the rest, there is really not right or wrong. There is a lot of room for discussion, and you can only learn from experience. A constructive response, however, would have been a patient home. That is what is recommended on the Affordable Care Act, also known as Obamacare. In other words, a place where what I think is really important, I don't know if we will ever get there, but a person where a patient calls, especially an older patient, and talks with one person, and this person is able to talk not with the recording, okay? Say, does not have to hear the thing that I love. This call may be monitored for quality improvement. I don't know, that's... somebody will say, hi, and that is possible, okay? I was saying about a year ago, I referred a patient to the Mayo Clinic in Jacksonville, and I was astonished that I called there in half a minute, a person answered the phone. And in 2.5 minutes, my patient was scheduled for an appointment. I didn't think that could happen, but Jefferson happens or not?
Jefferson,
Yeah.
maybe not. Maybe, but Penn it doesn't happen.
Oh, Penn, I'm sorry. I don't know why I say sorry. So I think that will be really important. Second, to have the possibility of home visits. And third, the possibility of telemedicine. And finally, who should be responsible for the coordination of care of this patient? Who should tell her, who should get the cardiologist and the urologist together and say, we can stop the darn warfarin and take care of the pain? This is something which is completely missing. I don't know what is the solution. All I know is that we cannot act this way. Okay, thank you.
Well, thanks everyone for hanging in. I think we have to do the, remember a couple of days ago we did those questions? So we're going to do them again. So see if you were awake during the last 8 hours. So
You're going to show the before and after?
John, is that how it works? Yeah. Okay. We're almost finished. So is this, well, I mean, Martine, why would you say the right answer is C? Probably C.
If you an average health, she would be between 10 and 15. So
Yeah, so it's C.
She can already have 15.
Yeah,
What's the right answer?
probably C.
D.
Yeah.
Just click there, next slide. Yeah.
I said C, but all right. Maybe it'll change. Maybe it'll improve soon.
And so that was a before and after. First, second.
Okay, what is the median age of death of colorectal cancer? I don't know if we've actually discussed this. I said the age of death also. Okay. So D, yeah. It's actually, according to the latest SEER, it's 74. But a lot of people do underestimate that. That's good. Excellent educational experience. I think we'll get this one. Interesting.
See what it was before and after.
Good, 70%. CLL, median age of diagnosis, and Conti had mentioned this. Whoops, I'm sorry. I have my own learning curve with this thing, I guess. Sorry about that.
Maybe you should take another course.
You're right. Well, like you, I click a lot. I take a clicking course. I once complained to administration. It took 13 clicks to order a flu shot. So I told people to go to Walgreens instead. All right, so I'm sorry. I apologize for this one. Yeah. and this question about prostate cancer. Okay.
Well, I agree to say that probably Cell is effective at
Well, thanks everyone for coming. Join SIOG. Hopefully we'll have a second U.S. SIOG forum thanks to Plexus and everyone's hard work. So, and have a safe trip back to wherever you're going.
And thanks. Just a quick reminder to turn in your evaluations. I don't want to. They were clapping for you, and I didn't want them to stop clapping. But 2 sides on the evaluation. Make sure you turn in the key cards. Please leave them outside with one of the staff. And thanks so much for taking the time on a Saturday all day to do this. We appreciate it, and there was a lot of information that was shared. Thank you.